My name is Alyssa Chin, and today we have Chris and Manvir. We were all on our psychiatry rotation together and came across this interesting case. It's a divergent phenotype assessing hypermobility in an adult with treatment-resistant depression and general anxiety disorder. To start off, we're going to present the case. Miss J is a 51-year-old Caucasian female who presented to an outpatient psychiatry clinic for her routine transcranial magnetic stimulation, also known as TMS. This was to treat her long-standing depression and generalized anxiety disorder. Upon talking with the patient, we noted that she had a history of TMJ, which was resolved with TMS, as well as an intolerance to anesthesia, chronic joint and limb pain, and she was previously a swimmer. These clusters of symptoms led us to kind of work up a possible diagnosis of generalized joint hypermobility in this patient. So to give some background information, we'll start with major depressive disorder. Major depressive disorder has been ranked as one of the third cause of burden of disease worldwide in 2008, and it's predicted to rank first by 2030. So it's a rising problem in our general population. According to the DSM-5, it is classified as at least 4 of the CIGI-CAPS symptoms mentioned below, and either the presence of a depressive mood or anhedonia, which is lack of interest. And this has to be persistent for at least 2 weeks. You also have to rule out a history of manic or hypomanic episode, because if a manic or hypomanic episode was present, that would be bipolar disorder. There are some tools to kind of assess depression in patients. One of the tools is the Beck's Depression Inventory. It is a 21-question survey that the patients will take. Each question has 3 points with a total of 63 points. You'll tally up the points, and each range of points classifies depression as either mild, borderline, moderate, severe, or extreme. There's also another tool known as the RAND-36. This was developed in 1992. It takes into account physical functioning, emotion, energy, to kind of assess the quality of life in these patients. It is also a self-survey that the patients will take. Some pharmacological treatments include SSRIs, which is first line, SNRIs, which can be used for neuropathic pain, as well as atypical antidepressants, which is used if the patients get sexual side effects from SSRIs or SNRIs. There's also TCAs and MAOIs, but they're not as used due to the side effects that has been reported. And if pharmacological treatments do not help alleviate the depressive symptoms, there's also therapy. The first one, as known as the gold standard, is electroconvulsive therapy. This is when we pass mild electric current to the brain through electrodes. The patients have to be under anesthesia, so there is some risk factors and lots of side effects. Due to the risk factors and side effects, patients actually have been preferring TMS, which is known as transcranial magnetic stimulation. This is a non-invasive form of brain stimulation, which changes the magnetic field and induces an electric current at specific areas in the brain, whether if they have depression or anxiety, because that's mapped in different areas of the brain. And I'll pass it on to my colleague Manvir to talk about generalized anxiety disorder.
Thank you, Alyssa. Hi, everyone. My name is Manvir. So I'm going to talk about generalized anxiety disorders. So basically, it's defined by constant worrying, fear, and feelings of being overwhelmed. So we have some criteria that we use to diagnose it. So patients must have at least 6 months of excessive worrying, and it must include at least 3 to 6 of the following symptoms. So we have a mnemonic for it. It's called worry warts. So I'll go through that. So it's wound up, worn out, absent-minded, restlessness, tension in muscle, and sleep disturbance. Next slide, please. Oh, for this part, so pharmacological treatments. So the first line treatment for generalized anxiety disorder is SSRI and SNRI. Alyssa just talked about this, so I won't get too much into it. We also have other medications that we use for coexisting conditions like panic disorder and erectile dysfunction. Again, I won't get too much into it. I just want to focus on the first line treatment, which is SSRI and SNRI. Next slide, please. For this part, I'm going to hand it off to Chris.
Thank you, Manvir. My name's Chris. I'll be discussing the hypermobility aspect of the case. So to begin, what is joint hypermobility syndrome or generalized joint hypermobility? What are we really talking about? So this is a systemic condition that originates in the musculoskeletal system, or at least is thought to, that is traditionally underreported and frequently misdiagnosed. One of the problems with this condition is that there's some nosologic confusion as to what it truly is. So in the literature, you can use or see interchangeable terms, often describing the same condition. Those terms, whether they're EDS, hypermobility type, hypermobile spectrum disorder, generalized joint hypermobility syndrome. It is thought as of 2017 that these are all similar, if not the same entity, actually. And so what does this actually mean? If we look at the joint manifestations, hypermobility literally means moving beyond the normal range of motion in a single joint. But this comes with a host of different symptoms, namely ligamentous laxity, pain, weakness, and importantly, pain in other areas of the body outside of the joint itself. If I can turn your attention to the right, the psychiatric manifestations or correlations of this condition have been expanded upon in the literature and include a wide array of conditions. Next slide, please. So if you look at the non-orthopedic manifestations of hypermobility, it's pretty daunting. In the literature, each of these conditions has been linked in some way or shape to this condition. And I'm not going to run through each of them, but as you can see, it encompasses many organ systems outside of the traditional musculoskeletal system. Next slide, please. So focusing on the psychiatric manifestations, these types of patients actually have a 10-fold increased chance of having an anxiety disorder. They're 22 times more likely to suffer from panic and agoraphobic disorders. Additionally, the presence of any pain syndrome in patients with EDS hypermobility type is significantly associated with a psychiatric disorder. And additionally, looking at the cluster of symptomology in these patients, the co-occurrence of these psychiatric conditions are present in many of these hypermobile patients. One of the interesting aspects of this condition looks at the fear avoidance model, which can be applied to a lot of different disease progressions. But these patients may change their behavior or change their activity based on how they perceive their condition to be progressing. So if they have hip pain, and they want to go for a walk, they are worried that their hip pain is going to get worse after that walk, and so they opt to not go for that walk at all, which again can be dangerous in many of these patients. Next slide, please. This was an interesting write-up that we found that looks at a patient's perspective of what they're going through, and we found that it was pretty powerful. And I'd like to read this quote pretty quickly here. "I felt like my physical health problems were being invalidated. As my physical health deteriorated, the exhaustion from fighting to be believed and to get appropriate help made me feel like my life was too difficult. This even led to suicide attempts." So the debilitation is extremely real in these patients. But again, it's difficult to diagnose. And so many of these patients have resentment of the healthcare system. They feel unheard. And this case echoes that. Next slide, please. So how do we assess hypermobility? What are the tools that we have at our disposal? Looking at the Baton scoring system, this was developed in the 70s. I'm sure many of you are familiar with this system, as it is commonly used to assess Ehlers-Danlos, or presence or absence of Ehlers-Danlos syndrome in patients. But it's also assessed to use hypermobility within the framework of Ehlers-Danlos. Looking at the specific criteria, you can see that there are many different measurements for different joints in the body, ranging from your hands all the way to your spine, elbows, knees, etc. And so to meet diagnostic criteria for Ehlers-Danlos syndrome, you'd need at least 4 out of these 9 symptoms. Next slide, please. The Villafranc criteria was developed by a group of experts in 1997. They actually met in Villafranc, Germany, because there was so much confusion over Ehlers-Danlos and hypermobility and what they were actually looking at, that they had to get together and really define it. And so this came out in 1997, excuse me. And each subtype of Ehlers-Danlos has their own criteria. The criteria that you see on your right is just the hypermobility type. There are other forms of Ehlers-Danlos, including kyphoscoliotic, vascular, et cetera, et cetera. But these are the major and minor criteria for the hypermobility type. To meet criteria for hypermobility, you need at least 2 major criteria. And there is a secondary set of diagnostic criteria that include at least 1 major and 1 minor criteria, but that's only for subtypes that have a molecular basis. Unfortunately, for the hypermobility type, it's the only subtype that has a mostly unknown genetic basis to it, which means that we can't use that criteria to assess Miss J. Next slide, please. Finally, the Hakim-Graham 5-point questionnaire was developed by 2 of the leading experts in the field. And they really created a scoring system that looked at the history of the patient. So they included things like, can you now or could you ever, which was an important development in the assessment of these types of patients, because the other tools we have only look at, how do you feel today when you're coming into the clinic? And this really progressed the field leaps and bounds in terms of what we're looking at with hypermobility. And so endorsing 2 or more of these questions would meet criteria for that diagnosis. Next slide, please. And so I'd like to hand it off to Alyssa to discuss the HPI of Ms. J.
Thank you, Chris. So now that we have a background and overview of MDD, GAD, and joint hypermobility, we're going to bring it back to Ms. J's case as we investigate more of her symptoms and history. So starting with her history of present illness, during her first pregnancy, unfortunately, it ended in a miscarriage at 4 months. And afterwards, they found an active thyroid nodule for which she started anti-thyroid treatment. This affected her sleep and mood, and she was started on sleep medication. And it also exacerbated her pre-existing anxiety. During her second pregnancy, which was full term, she received radiation to the thyroid afterwards. And this also led to increased anxiety and depression. She was started on Paxil, which is also known as paroxetine, and it was effective for 25 years, but it also worsened her TMJ issues bilaterally. During the recent COVID pandemic, she also noted worsening anxiety due to the increased workload she had at work and at home. She had a major depressive episode in 2021, and this led her to seeking professional psychiatric specialist for the very first time. Previously, she was only seeing a general practitioner. This psychiatrist started her on Zoloft, which is also known as sertraline. He also continued the Ambien and discontinued the Paxil, which improved her TMJ issues. From 2022 to the present, she had major anxiety, which led to 25 pounds of weight loss, 9 days without sleep, and all her medications appeared to stop working. This led her to begin ECT at Stanford, which again is the gold standard currently for treatment-resistant major depressive disorder. But for this patient, she reported very little to no effect. And also, this was the first time she noticed her intolerance to the anesthesia. Next, she then began trying TMS at the outpatient psychiatry clinic, and this had great results. It alleviated a lot of her symptoms and also decreased her TMJ pain. When we met her, she was receiving TMS for about 2 months already. Now I'll bring it to Manvir, who will discuss the rest of her physical and history.
Thank you, Alyssa. So for review of systems, it's pretty extensive, but what I'd like to focus in on is dermatographic urticaria. So she was positive for this, and it's pretty interesting. So basically, we were able to make some marks on her skin. It would basically show letters or like a map on her skin because of skin irritation. She also had prolonged wound healing, stretch marks, and easy bruising. Alyssa talked about this previously, but she had persistent TMJ pain, unintentional weight loss of 25 pounds. Her vision was impaired at -1.25 and -1, and she had astigmatism. I'll move on to the next slide. So for past medical history, again, she had a history of anxiety, depression, gastritis, GERD, high cholesterol, hypertension, and irradiation. She had some surgeries in the past. And for allergies, what was notable was that she had skin wounds that would occur due to adhesives. When she was exposed to grass and trees, she got a runny nose, headache, and she had sneezing. And she was allergic to sulfa drugs, which caused GI upset. Next slide, please. For medications, I'll just focus in on the ones that are relevant. So she was taking Ambien, lorazepam, Seroquel, and she was previously on Paxil and Zoloft. Next slide, please. For social history, I kind of just wanted to focus in on sport history, which is more relevant to our case. So she used to swim for 5 to 6 years between middle to high school, and she played on the monkey bars as a child. So this is pretty cool because it's a pretty interesting connection to our study on joint hypermobility. She had this history in the past where she was pretty active, and so I thought that would be cool to mention. Next slide, please. For family history, I wanted to focus in on the relatives that also have anxiety and depression, so it's pretty extensive. So her mother had anxiety and depression, her father, her grandmother on her maternal side, uncle, sister, and nephew. Next slide, please. So for physical exam, I didn't want to go through the entire thing, but on physical experience, general appearance, she was not in acute she was not in acute distress. She was calm, she had a good mood, and she did not have any current depressive symptoms at the time. So for our MSK exam, we did notice that in multiple joints, she did have excessive range of motion. And for a neurologic exam, we had her walk in the hallway, and we noticed that she had a positive Trendelenburg sign on the right. Next slide, please. Okay, so I'm going to hand it back to Chris.
Yeah, so I'm going to discuss the results of Miss J's hypermobility assessment. Looking at her Baton score, she received a 3 out of 9, which technically does not meet criteria for Ehlers-Danlos hypermobility type. You'd need 4 out of 9 to meet the diagnosis. Next, we can look at her Hakim-Graham 5-point questionnaire. She needed to meet hypermobile diagnosis. She needed at least 2. She got 3 out of 5, so that meets criteria for hypermobility. Next slide. Looking at her Villafranc criteria, she reported 1 major and 1 minor symptom. But again, because we don't have a molecular basis, we can't use the minor criteria to aid in our diagnosis here. So she did not meet criteria for the Villafranc scale. Next slide, please. Looking at her psychiatric assessment, this is really interesting because looking at her Beck's depression inventory score at 13, this places her in the mild mood disturbance category, which again is interesting because you're seeing somebody with treatment-resistant depression who's had about 30 ECT brain stimulation treatments in the past. And she's been receiving TMS at this point for about a month. So as Alyssa had said, and I'd like to echo, this is great news for her in that, it's a mild mood disturbance and not a mild depressive symptoms even. And so looking at her quality of life survey that we did, and again, this kind of breaks down, it's a self-administered survey that breaks down the different aspects of this patient's life and looking at kind of what is contributing to her debilitation psychiatrically. And so if you look at this red box, these 3 numbers were intriguing because her physical functioning is at a 95%, which is about as good as you can get. And then if you look at her role limitations due to physical health, it's 75%, whereas her role limitations to emotional problems are 0%. So what this survey is telling us is that her debilitation mentally she attributes it a lot to her physical health, which again, is pretty interesting to me with somebody with treatment-resistant depression and generalized anxiety. Next slide. So conclusion, so looking at what we found in Miss J, we found that she does have a mild mood disturbance. And again, this could be secondary to her recent TMS brain stimulation treatments, which have been working for her and she's reacted positively to, which is great news again. Looking at her hypermobility scores, she met criteria only on the Hakeem-Graham 5-point questionnaire. But there are some caveats and some extra things to consider that I'd like us to think about. We recognize that the nature of the disease progression for hypermobility, it tends to decrease with age. It can't increase with age, but it usually decreases with age. And so because of this, we tested her at 51 years old. If we would have given her these scores at 20 years old, would these scores be any different? And that's really the question, is early diagnosis of this condition can alleviate lots of the problems and debilitation faced by these patients. And then, so we think that, how Ms. J is scoring currently may not accurately reflect her hypermobility status. Next slide, please. So the future directions, again, going back to the molecular and genetic basis of this disease, we don't have a molecule or a gene or anything like that we can accurately say, hey, if you have this, you have hypermobility. And that's a recent area of research interest in the field of rheumatology, namely, is trying to elucidate that molecule and seeing, how does this tie into the genetics of these patients? Next, I think that, quantitatively defining hypermobility, so what is true hypermobility in a joint, is extremely important, because lots of these diagnoses are clinical. Clinicians need to be aware that these patients have these types of problems. And if we don't have good ways to measure that, then they will face debilitation as well. And so, using biplane radiography and other modalities, it's important to quantify, well, if we look at the C-spine, what is a hypermobile C-spine? What does that truly mean? And so I think that that's a future direction as well. And again, developing, scoring systems, or at least collating the criteria to better capture these types of patients into a hypermobility status, and creating a tool that is sensitive for it is extremely important. These tools we're using were developed in the 70s and the 90s, and using them all together may be a good thing for patients, but again, it's worth revisiting. And I think that that's it. I think the next slide is references or resources. So if anybody has any questions, we'd be happy to answer them. Thank you.
So student doctors, I'd just like to point out what a beautiful example of collaboration. It's really a pleasure to see KCU student doctors in their third year meet up out in the field and maybe put in place a little bit of what we likely taught you in year 1 and 2 as a collaborative team. This bodes well for your future career trajectory, because collaboration is key. And you guys did an excellent job, not only in the presentation per se, but in approaching this case. So there's a couple of hands up. Let's see, Kelly Joy, go ahead.
Oh, thank you very much. I just want to say how, again, how proud I am to see you guys present this case. It's amazing. I also want to say a few words about this case particularly. When at my last job in a clinic, I got put on a website that said I was good at treating Ehlers-Danlos. So I saw lots of Ehlers-Danlos and mobility disorders. And I think you're absolutely right that the early diagnosis of that is a whole lot easier with the tools that you're given, but it doesn't necessarily give you much insight into your 51-year-old patient. Your 51-year-old patient has been following Wolff's Law all of her life, laying down calcium along lines of stress, and has been making those joints tighter through abnormal ways. So I just want to say, yes, absolutely. I'm going to steer you away from thinking about radiologic diagnosis from a term of x-rays, because that's a lot of joints to x-ray. But I will say that if your tool never gets out of your toolbox, then it doesn't work. So, actually having people who are looking at those tools and using the tools that we have would be very effective at helping us screen those people. I will say from having seen a lot of hypermobile people, a lot of them do have psychiatric issues. And then we gaslight them to tell them that they're wrong about their psychiatric issues, which only after 40 years of being told, oh, your joints are fine, it's great, only leads to more depressive symptoms and other issues. So I think this case is a great example of how healthcare, if we're not looking for things like this, we can miss them and can have significant life sequela based on the healthcare we've given. So thank you.
Dr. J, go ahead.
First of all, I'd like to ask the students, what year are you currently in? Are you third or fourth years?
Third years.
All third years. I think what we've seen beginning of this year, and this may be looking back for the last couple of years, one of the finest presentations that I've heard. This was so well organized, so well presented, and the depth of this presentation I was really impressed with, pertinent to getting back to some of the basics. And the basics were tell me your history. And you guys dived into the past medical history very, very well. You took us through the review of systems equally well, and all of those are extremely important. And you did a great physical examination. At least you enunciated and told us about the abnormalities on the physical exam. Well, what that is, it's all holistic approach. And you guys put it together in such a way that it was outstanding. I had maybe a handful in my career of few patients that had Ehlers-Danlos syndrome. And I wasn't smart enough at the time to look back and to try to correlate some of the underlying psychologic or psychiatric manifestations that they may have suffered from. So I totally missed that. And I truly appreciate the way you guys have presented this to put it together for making sure that you don't miss anything in this process. So I really appreciated this presentation. I only have one question to ask, and it's relevant to, and I think it's Manvir's presentation and commentary. And you had mentioned, and maybe I misunderstood, that they had a particular sign. I thought that you had mentioned Trendelenburg. And did I misunderstand what you meant?
No, you're correct. So we did watch her gait, and her hip did. So we noticed that she had a positive Trendelenburg sign on the right. So we had her walk Trendelenburg.
Okay. All right. Are you familiar with Trendelenburg position?
Yes.
Okay, so tell me what a Trendelenburg sign is.
So when she's walking, the hip on the right was higher than the left, if I'm saying that correctly.
So I'm thinking that you're mentioning a Trendelenburg gait rather than a sign. So the sign would be if you put your hands on the hips and they lift up the foot and one drops.
Yeah.
And then Trendelenburg gait is where they're not using that glute medius and that hip internally rotates.
Okay, yes. So I meant thank you for the correction.
No, you're fine. I just want to make sure you understood that. And Trendelenburg position is placing that head down in a manner that typically you want more blood to go to the brain. And oftentimes it's utilized in a hypotensive setting. So I just want to make sure that I understood what you meant by Trendelenburg sign. Okay.
Thank you.
Outstanding quality of presentation. And, I think all the doctors that are on this screen right now can look at this group of medical students and say,